Welcome back to our Neurology review series. Today we are focusing on the differential diagnosis of Parkinsonism, a crucial skill for postgraduate residents. We will divide the causes into three main categories, which are idiopathic Parkinson's disease, Parkinson Plus Syndromes, and secondary Parkinsonism. Let us start with classic Parkinson's disease. The pathophysiology involves the progressive loss of dopaminergic neurons in the substantia nigra pars compacta. Pathologically, this is characterized by the presence of Lewy bodies containing alpha-synuclein. Clinically, the onset of symptoms is typically asymmetrical. The core motor signs follow the TRAP acronym, which includes resting tremor, rigidity, akinesia or bradykinesia, and postural instability, though it is important to remember that significant postural instability is usually a later finding. A hallmark of idiopathic Parkinson's disease is an excellent and sustained clinical response to levodopa therapy. Other common clinical features include a slowly progressive disease course, hyposmia, chronic constipation, and rapid eye movement sleep behavior disorder. Next, we move to the Parkinson Plus Syndromes, which are also known as atypical Parkinsonism. These disorders involve much wider areas of neurodegeneration. There are several key examples you must be able to recognize. Progressive supranuclear palsy is classically characterized by vertical gaze palsy, prominent early falls, and pronounced axial rigidity. Multiple system atrophy can present as either a Parkinsonian or cerebellar subtype and typically features severe autonomic failure alongside cerebellar or pyramidal tract signs. Corticobasal syndrome is uniquely known for its presentation with the alien limb phenomenon, profound limb apraxia, and severe dystonia. Finally, dementia with Lewy bodies is distinguished by the onset of significant cognitive impairment occurring before or concurrently with the onset of motor symptoms, very often accompanied by vivid visual hallucinations. When comparing the general features of Parkinson Plus syndromes to typical Parkinson's disease, atypical variants often present with symmetrical symptoms at onset demonstrate a much more rapid disease progression and yield a notably poor or only transient response to levodopa therapy. Finally, we must always consider secondary Parkinsonism, where the motor symptoms are directly caused by an identifiable external factor or a separate underlying condition. Drug-induced Parkinsonism is incredibly common in clinical practice and is frequently caused by dopamine-blocking agents such as antipsychotics like haloperidol or antiemetics like metoclopramide. Vascular Parkinsonism often results from severe small vessel disease or multiple basal ganglia infarcts, and is sometimes referred to as lower body Parkinsonism due to its prominent effect on the patient's gait rather than their upper extremities. Toxic causes are rare but important and can include exposure to MPTP, manganese toxicity, or carbon monoxide poisoning. Traumatic etiologies encompass chronic traumatic encephalopathy and dementia pugilistica in patients with a history of repeated head injury. You must also keep metabolic and structural causes in mind, such as Wilson's disease or normal pressure hydrocephalus, as well as post-encephalitic or autoimmune inflammatory conditions. Systematically working through these categories will ensure you reach the correct diagnosis and provide the most appropriate management for your patients.